Foley caths. Okay, so remember earlier we talked about the best way to prevent Foley catheter infection is not to have a Foley cath in the first place. Okay. All right. So remember, Foley catheters are sterile because it's a tube that goes directly from the urethral. They call it a urethral meatus. That's your pee hole. Okay. Directly, yeah, urethral meatus. All right. Whatever. Anyway, so it goes directly into the bladder. So obviously that needs to be sterile when you put it in. Okay. Who needs a cath? Okay, now that's important to know because you need to know who absolutely has to have one and who is just for convenience, right? If they have urinary retention, and remember, urinary retention is in the bladder, not in the kidneys. That means that the bladder, for whatever reason, cannot relax and it cannot release urine. Now, what can happen is that urine can back up into the ureters, go into the kidneys, and cause hydronephrosis, and it can eventually cause kidney failure. Your bladder can also rupture because it can only hold so much, right? Wow. So it's very important to get urine out, right? Yeah. So urinary retention actually is a very big deal, but I want to be very clear. It is only in the bladder, right? Urinary retention means the bladder can't release. That's why a cath helps to relieve urinary retention. Okay.
Are there certain conditions that would not allow someone to,
Oh, like who gets urinary retention? Yeah. Okay, sure. So after anesthesia, so after any surgery, BPH, benign prostatic hypertrophy, so a big prostate, right? Enlarged prostate will do that. Patients with spinal cord injuries because they don't feel the need to go. Patients with multiple sclerosis. So there's lots of people who can get urinary retention. Anytime you've had any surgery of the private parts because everything swells afterwards. So for weeks after that, even if you get your prostate removed, you can get severe urinary retention because where you did surgery and cut something out, that tissue inflamed and swelled. And remember, it wraps around the bladder neck, right? All right, so urinary retention, if you need to obtain a sterile specimen, but if you need a sterile specimen, you really could just do a straight cath, okay? But if you have a Foley cath in place, you can take a specimen from the Foley cath, and it is considered sterile because it goes directly into the bladder, okay? If the patient is on very strict I's and O's, now they can still be continent and do that, but sometimes they'll say, oh, because I need such strict I's and O's, put in a Foley. I disagree with that. They'll sometimes put in a Foley if they need strict I's and O's. So strict I's and O's means you better measure every single ounce of urine that comes out of that patient. Yes. Well, I can still do that if they don't have a Foley cath. But yeah, because they'll just say like every time you go to the bathroom, I put it, I measure it, right? But sometimes if they don't trust the patient or something, like they'll just say put in a cath. But that just puts them at high risk of it's easier. So that to me screams convenience. Yeah, that's gross. All right, if they have pressure ulcers or wounds in the perineal area, that if urine hits it, it will burn it. Okay, so I could see that sometimes. If they have prolonged immobilization, now I don't agree with that. Okay, because prolonged immobilization, you're just sticking a Foley in them. It seems very lazy. If they are post-surgery, now a lot of times people after surgery will come out with Foley casts. Totally understand that your bladder is not contracting yet, right? So I get that. Okay, but we need to get it out as soon as possible. Yeah. All right, different options for Foleys. So you know what a lumen is? That's a tube, right? And have we talked about central? Lumen usually means the size, but it just means it's a tube. Okay. So there is a single lumen Foley. That's probably the one you did check-offs with, right? Like a normal one tube. Oh, okay. So it's one tube. Oh, I see. I'll make sure you watch that video then. There's a double lumen where there's two tubes, okay? And those tubes, one of them has a balloon, just like the normal Foley, and then the other one is for some kind of extra drainage, okay? And they may put the second one somewhere else, okay? So there's two tubes that go inside. It could be extra urine drainage. You can also use it to irrigate, okay? So we can put solution in, and then it has the other tube for solution to come out. Okay. And that's what we use a triple lumen for as well. So sometimes with triple lumen, you'll have one that has a balloon to keep it in place. You'll have a second tube that drains the urine. And then you'll have a third tube that we can perform irrigation through. Oh, so when you're yeah. But the one with the balloon, remember, does have a hole in it. So you can use that as well. So it really just depends on your patient, what you're using it for. But most of the Foleys you'll see is just single lumen, just one tube. Okay. Just to note, the size is usually between 12 and 16 French. I don't know if you've seen this meme that runs around. It's really kind of ugly, but there's a meme that says, when you're being ugly to me as your nurse, remember I choose your catheter size. Oh. So, I know that's really ugly, but it is what it is. So you get to choose the size depending on what the size of the patient is, right? So usually on our bigger obese patients, we use a bigger size, right? So you kind of have to go and look and see what you're dealing with, but that's about the size. Okay. And then the balloon will inflate. I know, I love memes too. I think they're so funny. 5 to 10 mLs is what you blow it up to. Most of the time it's 10, the balloon. You have to put 10 cc's of saline in there, right, to keep the balloon inflated. Okay. Okay. You know that Foleys have a high risk of CAUTI, which is catheter associated urinary tract infection. Yeah. All right. The best way to prevent a CAUTI is always pick good hand washing. You're always going to pick that too, right? But take out the cath, right? That would be the best way. But if it says good hand washing, you know, you pick that 100% of the time, no matter what question they're asking you, you pick good hand washing. Okay. All right. Yep. Always pick it. All right. Important things to know. Oh, no, actually, let's go to insertion. Right? Let's talk about putting it in. Okay. Have you already looked at this, or do you have an idea of what I'm talking about? No. Okay. But you know, okay, so here's the Foley cast. You can kind of see what it looks like, right? You've got a tube, and this has a little hole in it so that it can drain urine. It also has a balloon to keep it in place. Oh, yeah. And then this tube is going to connect to a urine bag. Okay. So for any time something is draining on a patient, I don't care what it is, it has to be below the level of the patient. Whether it's a chest tube, it's urine, you're collecting something, it has to be below the level or it won't drain, right? All right, so insertions, you're going to put them in either dorsal recumbent, that's when they're back, and then they're going to put their knees up, right? That's for like ladies, right? You can also put them in sim. So if they're not able to put their knees like that, like some older ladies may not be able to do that, 80 or 90-year-old woman or something. Yeah, if you can't do that, then you can put them in the Sims position, which is the enema position, right, where they're on their belly with their leg up. It's very difficult to insert in because you have to go through the back. Yeah. Oh yeah, because that's it's tough to insert that way. Yeah. You can see it. Yeah. Yes, very, very difficult. And especially in that position. And then you can also put on lateral, which is on their side. Again, very difficult insertion. Okay. All right. You always stand on the side of the bed. That's your dominant hand. So if your dominant hand is right side, you stand on the right side of the patient. Okay. Because you're going to end up going like this, right? Yeah. All right. Clean the perineal area first, just with soap and water. We're just going to clean the whole thing first. Okay. And then pat it. Remember, let it dry. Okay. Now everything's clean. Now we're ready to get sterile. Okay. So you're going to have them open their legs a little bit and you put the cath sets like this, you're going to set up your sterile field between their legs. Okay. So you open the sterile cath kit, you put the sterile drape under their bottom. So that way, if anything drips or whatever, it'll come that way, but make sure that your hands stay on the top because once you touch the patient, you're not sterile anymore. Right. And then you're going to clean with iodine. Before you clean because it has to be sterile. Right. So you're going to clean with iodine from the top to the bottom. Remember, we talked about in wound care, every time you finish one, you discard it, right? So you're going to go from top to bottom, throw out, top to bottom, throw out, top to bottom, throw out. You need to make sure you test the balloon before you put it in the patient to make sure it actually does inflate. There's not a hole in it or anything like that. So inside your cath kit, you'll have a 10 ml syringe. You're going to connect it to, because you're sterile and everything inside is sterile. You're going to connect it to the cath, blow it up to make sure that it blows up and then deflate it because you can't stick it in that way, obviously. So you're like, okay, that's done. I got this. And then you need to lubricate the tip. It does come with a lubricant in the cath kit as well. Okay, so lubricate the tip so it goes in well and it's not painful. Okay. And then use your non-dominant hand, if it's a lady, of course, to spread open the labia and you need to pull up. Otherwise you can't see nothing. Okay, because there's a lot going on down there. Okay, so you're going to pull it open this and then pull it up. And that way you should be able to see 2 holes. Okay. And have you ever heard of the wink? Okay, so when you pull up, okay, you've got the vagina here and you got the urethra here, right? But sometimes like in obese patients or like in very elderly patients, it can be hard to see what's going on down there because there's like, you know, so there's a lot of stuff. So that's why you pull up and you pull up pretty tight, okay? And you should be able to see the holes that way, okay? The urethra is more muscular, so it will go like that at you. So if they say like, did you see the wink? It'll like kind of, yes, it winks at you. Like, hey girl, okay. So then you're going to go into the urethra. Now, if you go in and you find out, whoops, I was in the vagina. This is very important. You leave the tube in and you get, yes, you're going to get a whole new cath set, re-clean, okay? And then you're going to put it in the urethra. And then you take out the other one. The reason you do that is so you don't keep sticking in the vagina every single time. You have one that's already in that hole. It's occupying the space. So now I know which hole to go into. You see what I mean? Okay, so I know that sounds like totally gross, and I would never pick that on an exam unless somebody told me, like, girl, what? Okay. Right, so that way you don't, spend 6 cath kits trying to find the right hole, right? Okay. And then you're going to advance the tube until you get urine return. And for some people, that has to go in a lot before you actually get urine return. Okay. It just like with any tube, if you meet resistance, you do not force a tube. That's any tube in all of nursing, right? Okay. So once you get it in, you get urine return. It's all connected to this nice little bag. You hang the bag off the side of the bed, right below the level of the patient. All right. Putting in a cath, a sterile procedure. We clean with iodine, and it comes with little cotton balls that you can dip in iodine and clean, or it comes as an iodine stick, right? Like a little lozenge. All right. Perineal care every shift. This is a non-negotiable. Okay. So clean with soap and water every shift to make sure they don't get a UTI. Okay. The male Foley cath tubing can be secured and taped either to their thigh or to their abdomen. This is always tested on.
Oh, really?
Yes. I don't know why. Just the boys. Okay. Yeah. So if you're trying to secure it or they're going to ambulate or whatever, you will tape it to their thigh. Okay. Or you tape it right here to their abdomen because it's like right there. Well, I mean, no, I think that'd be kind of more painful. I mean, you could tape it to her thigh, I guess, but for whatever reason, they always ask about dudes. Okay. The balloon should be inflated to 10 mLs. I told you that. Keep the bag below the level of the bladder, but off the ground. We don't keep urine bags on the ground because they'll spill and get dirty and all kinds of things. We do encourage fluid intake and still watch for signs of UTI. And then every single day, you may have to advocate for your patient, like, let's take this out. Like, she doesn't need it. She feels the need to go. Can we take this out today? Okay. And when the doctor says, yes, we can take this out today. Okay. Yeah. In order to remove it. So there's removal right here. Right here. Okay. So you're going to deflate the balloon. Okay. Please make sure you do that. Otherwise that would hurt very, very badly to pull a balloon through your urethra. Okay. So don't forget to deflate the balloon. Yep. Ouch. Ask the patient to take a deep breath. Okay. And then you pull. Okay. And then you're going to clean up the area down there, perform perineal care. Okay. They may have a little bit of burning with urination afterwards because that tube is not small and you've pulled it. No, it's huge, right? So for a couple days afterwards, it may burn. But if they run a fever and burning, that's probably a UTI. But if they're just like, oh, it burns a little bit when I pee, I'm like, yeah, we just took a cath out. I'm so sorry, And we do want to see them void within the next 8 to 10 hours. If they have not voided within 8 hours after removing the cath, you probably need to put it back in. Okay, because it may just be that they're not ready. Now, how do I know they're not ready? I didn't write this down, but now that I'm thinking about it, I want to tell you. So if you think somebody has urinary retention, right, where you think if they're like, I need to go, but I can't, the first thing you do is to palpate the bladder. And if it's very distended, you're like, oh, I think you got a lot of urine in here. I need to know how much. So there's a bladder scanner on every unit. It's a handheld little thing. Okay. So you'll always hear people asking, where's the bladder scanner? Where's the bladder scanner? Everybody needs it. Okay. So you go and get it, right? And it's just like a little ultrasounds. Yep. You can tell how much is in there. Yes. Yes. So I'm going to scan, like just do, it's like, looks like a little ultrasound wand you put over the bladder and it'll say, oh, there's 700 mLs. I'm like, crap. So then I got to call the doctor and say, hey, I just let you know, I took this patient's Foley out 5 hours ago. He hasn't voided yet. He thinks he needs to go, but he's very distended and he's got 700 mLs in his bladder. Can I get an order for a straight cath or do you want to Foley him again? Okay. And you can always just straight cath him and see if maybe over some time he develops that, or if the doctor's just like, forget it, just put a Foley in. That's an option too. Okay.
So what would be like considered like a lot like urinary retention over like 70 mLs? Like
oh, sure. So I mean, honestly, if they feel like they need to go and they literally cannot, I mean, that is urinary retention. But you won't cath until they have, I would say probably 400, maybe 300 or 400 in their bladder at one time. All right. What else I want to talk about? Oh, let's talk about these red flag things that I put up here. Okay. So the tubing should be secured to the patient's thigh. That is always testable. The tubing. Okay. Thigh or the abdomen. You can do the abdomen. Bag should always be below the level of the bladder. And usually how they ask this question is, you have a patient that has a Foley cath that is going to CT, right? The UAP comes to pick up the patient for CT, puts them in the wheelchair, and you notice that they hung the Foley bag next to or on the IV pole. What would you do? You would say, no. Yeah. And gently educate, right? Remember, if the cath is in the vagina, what do? You keep it in Leave it in place. Insert a new sterile into the urethra and then take out the other one, right? Okay. Yeah, or 3 times or 4. Sometimes you can't tell and you're just going blind like this, okay? Because I can't, there's too much, okay? If it is leaking, so sometimes it will leak around the area. If you notice that there's a lot of pee on the chuck or in a dude, if it's leaking around the like the pee hole, the urethral meatus, first assess the balloon and make sure that is blown up correctly, because it may be that the balloon is too loose and so it's leaking around. Okay, so assess the balloon. Okay, and just make sure that you have enough fluid in there, or go back and look and see how many mLs. The nurse may have only filled it with 5. Maybe you need to go up to 10, right? So assess a balloon. Assess for UTI, because the UTI can make them leak, right? So I would say, like, does it burn? Do you feel any burning? Look and see if they have any fever. Does your back hurt, right? So I'm looking for signs of UTI. Assess for constipation. So constipation can put too much pressure on the bladder and can cause it to leak, right? Because you have your bladder right here and your gut is right here. So if your gut is filled with poop, it can actually push on your bladder and cause it to just kind of like squeeze out the hole. Okay. And constipation also puts you at high risk of UTIs, because the poop and all the intestines being so full are pushing against the bladder, causing incomplete emptying. Okay. So anytime a patient has a urinary problem, oh yeah, I always ask about constipation first, because the majority of the time it's a constipation issue, not a urinary issue. And if we can fix the poop problem, then we can fix the pee problem.
And that'll automatically take care of
a lot of times it's constipation. Yeah, especially in kids that I see that come back with recurrent UTIs. The first question I'll ask is, do they have a history of constipation? Let's try to fix that first, and then see if that fixes the urinary problems. Yep. All right, so assess for constipation, and then if all else fails and it's still leaking, just replace the Foley cath. Do not put in a larger cath, because that can be very damaging to the urethra. Okay, so if it's leaking, that's how to troubleshoot. Okay. Any questions on caths?
No.
Okay.